Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center of Miami, and wishing you a great day. And today's topic for our Instagram chat is preimplantation genetic testing, or PGT-A. How do I know if my embryos are normal or acceptable for transfer? First, just to review, there are different types of genetic testing that are done in patients undergoing fertility treatment. Usually before we do anything, in addition to taking a medical history, we do a blood test on both the female and male members of the couple and do what's called usually a SEMA4 panel. There are 4 or 5 other additional panels available by other companies, but the purpose of that is to look at the mother and the father of the potential child to see whether they are carrying any abnormal mutations that could affect the child. In other words, you're normal, but when you go to have the egg and sperm get together, the embryo might not be normal. And that's testing that's done before getting pregnant. If you complement each other where you're not having the same abnormality, then there's nothing to worry about. But if you both carry the same gene, for instance, for cystic fibrosis, then we want to be able to test the embryo for that specific abnormality. When you test the embryo for that, that's called preimplantation genetic testing for single gene defect or mutation testing. And that's different than what I'm chatting about today. Today we're chatting about what most of our patients elect to have done on a regular IVF cycle, where once the egg has been fertilized with sperm, or the eggs usually, you let the embryos develop, and then on the 5th and 6th day of development, when the embryo is between 50 and 70 cells, before deciding which embryo to transfer, we want to test to see whether that embryo is genetically competent. And genetic competence at this point, and what we're looking for, is to see whether the embryo is aneuploid or not. And what aneuploid means is an abnormal chromosome number. Basically, most people have 46 chromosomes, 2 of each of 23, one of those being the sex chromosomes. And in a female embryo, you have 2 X's, and in a male embryo, 1 X and Y chromosome. So the benefit we get from doing preimplantation genetic testing for aneuploidy, or PGT-A, which historically was called PGT-S, or just preimplantation genetic screening, is to know that with 98% accuracy that the embryo selected for transfer, at least from a genetic standpoint, should be competent to develop into a child with the same genetics. When you do testing of these embryos, the embryo looks like a little soccer ball, and the cells on the outside of the soccer ball are the placental cells. And you can biopsy these future placental cells, or the chorionic membrane, to see whether they're containing the correct number of chromosomes. So that's done and the embryos are frozen. The reason we have to freeze the embryos is to take 7 to 10 days for those results to come back. And so the embryos have to be frozen, and then we can decide which are normal, which are abnormal, and then use a programmed cycle where we turn off the woman's menstrual flow, usually with Lupron, and then start you up on estrogen in the form of patches or oral estrogen to develop the thickness of the lining. And in the mid-cycle of the lining, when it develops, it's at least 7 and hopefully 8 to 12 millimeter range, but at least 7 and no more than 16 that range is really the sweet spot, and we aim to put the embryos back at that point. So when we send these embryos out, we can get a couple different results. Most commonly, it's going to be sort of a black and white answer. It's going to come back and tell us the embryo is euploid, meaning everything looks okay, or it's aneuploid, meaning that there's an abnormal chromosome complement there. In either event, it will tell us if it has 1 or 2 X and Y chromosomes, and so we can identify which embryos are female embryos and which embryos are male embryos. And if we have both available, then obviously it's up to the couple which one they would like to transfer. We do recommend a single embryo transfer on a frozen embryo transfer cycle particularly with biopsied embryos, to avoid the incidence and risks associated with multiple birth. So most of the time it comes back euploid, that's great. It comes back aneuploid, that's abnormal. We don't recommend transferring those embryos, and our consent forms are such that those embryos will automatically get discarded. Occasionally, we can get one or two other interpretations. Sometimes we'll get back, and it's less than 5% of embryos, we get back a non-indeterminate genetic result, or a low DNA result. It just means that they didn't get a clear enough signal from the analysis of the DNA to say whether it's normal or abnormal. So if you get back a result that says low DNA or indeterminate, it's the same as having not had the biopsy in the first place. And with these embryos, we recommend keeping them. We recommend considering transferring them, but to have that be the last resort rather than the first resort of embryos, because obviously if somebody is 36 years old and the incidence of aneuploidy is 50%, we get a 50-50 chance that the embryo is going to be normal. Whereas if we know we have a normal embryo, we're going to have a much better outcome with the transfer. You can, if you have an indeterminate embryo, you theoretically can thaw it, rebiopsy it, refreeze it, and doing that does not cause the embryo to be abnormal in any way, but putting it through a whole nother process, taking some more cells out, may potentially make that embryo a little less viable to work. So we've done that on occasions, and we've done okay with it, but it's not our first choice. And the last result that we can get is called a mosaic embryo, and that's probably the most confusing. And when you get a report that says mosaicism, it means some of the DNA is telling you it's normal, and some of the DNA is saying it's an abnormal embryo. So it's not clear enough to say with certainty, meaning 98% certainty, that it's normal or abnormal. So it falls in this gray zone, basically. And high-order mosaic embryos have the great majority of their, over 60% of their analysis is abnormal. So we don't recommend transferring high-order mosaics. Low-order mosaics, usually where 20 to 40% of the cells are abnormal, we don't recommend transferring those in our center. There are some mosaic embryos that are low-level mosaicism that if they have genetics where it implies that even if it were to stick, it wouldn't cause any harm. The worst thing that would happen is you'd get a miscarriage or the embryo would just fail to implant. There are some programs that may choose to implant those, but you've got to be in an academic environment with an appropriate investigational review board protocol to be able to put mosaic embryos back. In our program, we do not transfer mosaic embryos, and we leave it up to the couple as an individual whether they want to keep those embryos frozen long-term or not. They automatically will be kept in storage, as we only discard aneuploid embryos, but we do not recommend transferring mosaic embryos, at least at this point in time. There may be more data down the road. So that's the whole thing in a nutshell. Again, pre-implantation genetic testing for aneuploidy is done on embryos on the 5th to 6th day of embryo development at the blastocyst stage. We biopsy the syncytial trophoblast, which is the exterior membrane around the embryo, the future placenta, and with 98% accuracy, it will tell us if that embryo has an acceptable genetic complement to transfer and result in a nice healthy baby. Aneuploid embryos are discarded. Indeterminate embryos are acceptable to transfer. They're similar to an embryo that has not been biopsied. And mosaic embryos, we don't recommend transferring, but it's still an area of active investigation. So when you have a euploid, acceptable embryo to transfer. The choice of gender, if we have multiple embryos, is up to you, but we do recommend one embryo at a time. Age affects if an embryo is normal or not, only in that the incidence of aneuploidy is age dependent, in that in somebody 30 years old, 70% of embryos are normal. In somebody 35, 36, it's going to be 50-50. And in somebody 40, it's going to be about 2/3 to 70% of embryos tested are going to be abnormal. In women 42 and above, 80% of embryos or more are abnormal. And that explains why it's more difficult for women that are older to get pregnant and why they have higher miscarriage rates, because of these abnormal embryos that just aren't going to continue to develop. So I hope that's helpful for everybody, and I wish you all a good afternoon and a nice, safe, healthy start of the week. Take care.